All right. Bill, thank you so much for joining us for our virtual advocacy days. I am excited for our advocates who are participating with us this year virtually. And I am looking forward to you being able to share your legislative update both on a federal and state level. So I will hand this over to you to give us some insight on what's going on within NHF and advocacy this year.
Sure. Thank you, Maureen. And for those of you who don't know me, my name is Bill Roby, and I'm Senior Manager for State Government Relations at NHF. I cover Nebraska, and I think today I cover 15 other states, so a total of 16 states from my home in Oregon. I cover mostly Western states, but all the way to Michigan and Wisconsin as well. So I thought I'd start really by just going over really quickly the results from Washington days. Which was very successful. We thought the evaluations were good, which is always important. We had a total of 300, I'm going to look at my notes here, 388 participants from 46 different states. And we had over 250 congressional meetings. So pretty successful for our first virtual Washington days. The interesting ask this year, in addition to our annual ask, which is for the appropriations for the Centers for Disease Control and National Institutes of Health and Health Resources and Services Administration. Kind of at the last minute, we were successful in working with a member of Congress to start a letter to get congressional signatures to go to President Biden, asking him to fix, if you will, the copay accumulator adjustment issue through a federal rulemaking. This is something we've been going back and forth with the previous administration the last few years, where the policy would be good and then it would be bad, so on and so forth. So this year, we asked people to ask their members of the House to co-sign what's known as the McEachin-Davis letter from Representatives McEachin and Davis. And to date, the deadline for signatures was extended until today. It was supposed to be last Friday. We had about 30 signatures. We wanted to push it another week to get more signatures. And the last I heard, which was on a call with our team yesterday, we were up to over 50 signatures as of yesterday. So hopefully we'll have a few more today. And we're pretty happy with that. And hopefully we'll get a member of the US Senate to start a similar letter. So that's where that stands. And thank you all, for all of you who participated in Washington days or who reached out to your congressional members afterward. Thank you so much. It's very important and very effective. All right, here, let's see. I'm going to I don't know if you want me to share my screen, Maureen, but I can kind of walk through some slides I have, or I can share it however you. Yeah. What's that?
You can share your screen if you feel comfortable with that. You should have the ability to do so. Yeah.
I got to make sure I get this right. Whoops. That's it. Is it coming up here?
Yeah, it's in just the full view right now.
Yeah, I'm trying to get it switched to slideshow. And it takes a little bit of time. And now it's in presenter view. You got presenter view?
I see presenter view.
Okay. Is that better?
That's perfect.
Okay. How do I get back up? Okay, so there we are today, my title sequence. So this year, all 50 states are in session. In the even numbered years, only 46 states are in session because 4 states meet every other year. What we were really concerned about going into the beginning of this year was state budgets. For obvious reasons, a lot of states' tax revenues took a big hit. There was a lot of spending in support of programs to support people during the pandemic. So we are really keeping a close eye on state budgets because tax revenues were forecast to be way down, not only this year, but probably next year as well. And essentially what you need to know about that is what we're worried about is how it impacts Medicaid. Medicaid funding is critical for many of our patients. Approximately 30% of our patients are on Medicaid. And so any cuts to Medicaid as states move to probably raise taxes and or trim their budgets is something we need to keep an eye on. And I'll give you an example of that, which I will touch on in more detail a little bit later. But last year, the state of Nevada, the legislature went into special session in the summertime, and the governor had asked the legislature to come back with, I don't remember what it was, but like 12% worth of budget cuts. And so one of the things that was put in the legislation to cut the budget was a proposal to carve out from Medicaid fee-for-service, as opposed to managed care, for the pharmacy benefit for 4 diseases. And one of those is hemophilia. There was HIV/AIDS, there was other immunodeficiency conditions, and then there was hemophilia. And so those were expensive drugs. The state proposed to carve those out and to serve those patients through a sole source pharmacy contract with Optum. And so that was an example of a proposal. I'll touch on more detail what we did about that later, but that's the kind of thing we were worried about keeping an eye on, is states trying to save money, and they do it on the backs of Medicaid. So 2 other areas of legislation where we're spending a lot of time this year, as we do every year. One is issue called step therapy. There's a sister issue called non-medical switching, where an insurance company may change their formulary mid-year. But NHF participates in a group called the SAME Coalition, the State Access to Innovative Medicine Coalition. It's a number of patient groups as well as a few manufacturers. And we work on legislation to create exceptions to payers' step therapy processes. Step therapy is a utilization management tool that payers use to control costs. And in many cases, it's just fine. But in some cases, it can really hurt people, especially those people with chronic diseases that don't have access to cheaper generic alternatives to expensive medication. So the SAME Coalition has been successful in getting legislation limiting the practice of step therapy in about 20 other states. And so this year, there's probably, the coalition's active in about a dozen states where legislation is moving. And there's some examples here. Arkansas really quickly in the session signed a good step therapy bill into law. I've been working with, including, we're going to talk about Nebraska, but Arizona as well, and Oregon has a bill as well, and I sit in on those coalition calls. And my colleagues, Nathan and Dylan, also sit in on coalition calls in other states. And so there's a number of bills moving that we're really actively involved in. And we're optimistic that we're going to have some success here in that area. It's still a little soon to predict that, but the Arizona bill has passed the Senate and is over in the House. The Oregon bill has had a hearing. California bill will come up soon. Louisiana at the end of 2020 was the only state to actually pass a step therapy bill last year. So a top priority for us is the issue of step therapy. The other one, which is called, the issue is out-of-pocket expenses. How much are patients paying out of pocket for their medications? Obviously, it's a huge issue for people with bleeding disorders that have very expensive medications. The SAME Coalition has model legislation that deals with that. Right now, it's only active in one other state, but where NHF has been active and is a key member of is a group called All Copays Count, which is a national coalition that my colleague Colette Culiano sits on and runs it along with the Arthritis Foundation. So we talked a lot about this at Washington Days. Obviously, that was the key part of the McEachin-Davis letter that we had the ask on, is a federal fix to this problem, because originally where we were seeing problems with copay accumulators was with employer-sponsored plans, which are federally regulated plans. The states really can't do much about that. I won't go into a lot of detail because it might seem confusing if I try to explain copay accumulators, but I would recommend if you go to our website, NHF's website, or even go to YouTube, and if you do a search on copay accumulators, NHF last year, or maybe over a year and a half ago now, produced a small animated cartoon that explains copay accumulators, we think, really well. It's on NHF's website. It's also really easy to find on YouTube. I think if you do that search, it's like the 3rd video down. And there's a number of other ones up there too. And we also have information on copay accumulator adjustment programs on NHF's CCSC website, which is the Comprehensive Care Sustainability Collaborative that we're a member of. And that's where Colette works as our payer relations person. And so we have material on that as well that we're certainly happy to get to if you want to contact Maureen we can share information with you. But I'm going to jump down to the next slide. This is why we're concerned. So this was an article I pulled off of a writer that I follow on LinkedIn, and he writes a blog called Drug Channels. And this is the prevalence of copay accumulator adjustment and something else called copay maximizers, these programs in commercial insurance over the last 4 years. And this was last year's slide, so 2021 is a projection, but you can see what direction it's going in. It's only going up. We've also got some recent information from the AIDS Institute that they did a study on the prevalence of copay accumulator adjustment programs in insurance plans. And we just talked about this it was on, I'm also working on this issue in Wisconsin. And we had our coalition call yesterday, and the AIDS Institute study got brought up. So I was just looking at it earlier. And in Nebraska, the estimate is it's in a kind of color-coded map of the United States, but it's about 60% or more of the marketplace plans in Nebraska have copay accumulator adjustment programs in their contracts. So again, this is really a top priority. 5 states and Puerto Rico adopted some kind of limitations on copay accumulators in the last couple of years. Virginia was actually the first state to do it. There's some variation in the legislation, but a good bill basically bans the use of copay accumulator adjustment programs. A decent bill, which is acceptable, is it does not allow, you can only use copay accumulator programs when the drug in question has a generic alternative. And of course we don't, which is why it's a huge concern to us. Our patients simply don't have access to cheaper medication. So this year, thanks to the All Copays Count Coalition, we've had legislation introduced in well over 20 states. I know we're working in coalition in states like Florida, Michigan, Oregon, Wisconsin, and it includes NHF staff as well as our chapters. 3 of those states up there, Michigan, Oregon, and Wisconsin, are mine, and I sit on coalition calls regularly with Oregon and Wisconsin, and follow it up in Michigan as well. But this is an active issue around the country. It's a huge priority for us. And so we want to get legislation adopted in each state that either bans copay accumulator adjustment programs or at least limits them, and so they don't affect our patients. A few other issues that we're working on and keeping an eye on, our chapters are involved in. In the last few years, I know the National Organization for Rare Diseases, NORD, has been pushing states to establish rare disease advisory councils. The very first one in the country was in North Carolina. And Charlene Cowell, who's the chapter exec in North Carolina of Hemophilia Foundation of North Carolina, actually is involved in that and sits on the council. Our West Virginia chapter as well was involved in passing legislation last year, and their executive director was appointed to the council as well. In fact, I think he's chairing it. So no good deed goes unpunished, if you will. And right now, I know our South Carolina, Hemophilia of South Carolina, our chapter there, is working to pass legislation in that state as well. And there's probably at least a dozen other states that have this rare disease advisory council legislation been introduced. There's also a number of states that have, very broadly, I would call them pharmacy benefit manager or PBM oversight. It's some kind of regulation over how PBMs operate, how much money they can keep in rebates and not share with pharmacists or patients. So there's many different aspects to that. But I know that's legislation we keep an eye on as well to make sure we're not impacted in any way.
Bill, can I ask you a question on, Nebraska has not seen a copay accumulator bill come through yet, as far as I'm aware. This seems like it's going to be a matter of when, not if. Is that our goal?
Yeah, it really will. And essentially for the folks out there watching this, if you're, for you advocates, people might ask, well, what makes a state a greater priority than another state? When you're, for those of us serving on national coalitions like the same coalition doesn't actually run the coalitions or the efforts in each state. They support state, sort of organic state coalitions. just like in Nebraska with the step therapy bill. There are people that are working on it that are part of the same coalition, but there really needs to be state leadership. And I know, for example, in Michigan, Sarah Precario, who is staff for the Hemophilia Foundation of Michigan, actually took that role on. I mean, the chapter is leading the coalition in Michigan, and Sarah actually testified on a hearing on a copay bill last week. So, and essentially, there's only so many people to cover so many states. I know my colleague with the Arthritis Foundation, who's based in California, there's only so many states he can cover, and he's leading a number of these efforts. So, if we get spread too thin, we just have to prioritize some states. But the goal is certainly probably the next legislative session to start all over again in states where we haven't passed anything. But I know with step therapy, we're pretty happy if in a typical year, 2 or 3 states pass a step therapy bill, because it's not easy to do. Insurance companies fight them. And the same thing with copay accumulator bills. They're not gonna, if we get 2 or 3 passed this year, I think that will be successful. And so we'll reevaluate next year kind of where to put our resources and what states to focus on. And I think also, Maureen, with Nebraska being a focus for step therapy this year, you can't fight battles on 2 fronts, if you will. You don't want to be fighting the payers on step therapy and copay accumulators. That's getting a little greedy, which is a challenge we've had in Oregon. Oregon has a step therapy bill and a copay accumulator bill. So we're kind of spread a little thin there, and the payers push back a lot on these things. So you're lucky if you can get one adopted. So, but it's something we'll continue to focus on, absent a federal fix, which is what we're hoping for.
That's wonderful. I think that's a really good insight to understand that because we're talking about copay accumulators on a national level a lot, and maybe why we aren't focusing on it on a local level as much this year, and putting our eggs in our step therapy basket. So Thank you for addressing why the copay accumulator is important, but not necessarily what our Nebraska advocates will be focusing on this year. Thank you.
Sure. And one other thing, because you're involved in the Nebraska step therapy effort, you have to find a bill sponsor. So you have to find a champion, and they're only going to pick so many fights for you. I mean, right? They'll be a champion, but it's often, finding the right person who's going to sponsor the bill and who's really going to, go to bat on your behalf. It's still up to the patient advocates, the groups, to move something forward. But you can only ask legislators for so much in a given year. And so, then I was looking at, again, a little inside baseball stuff. During the Wisconsin call, which is a really good coalition, they've got some contracted state lobbyists, and they drew up a table of the legislators who were trying to get to sponsor the copay accumulator bill. And they went back through the last 4 years and looked at the patient-friendly bills that those legislators had sponsored. So they actually do that kind of history to figure out who are the targets, who are likely to support, who are the people we have to persuade. So it really is, it's a very strategic approach to these things. And again, getting people to sign on and go to bat for you in the legislature when you need it. So anyway, just, it's all very interesting behind the scenes, how this stuff gets done. And it's different. And as I'm learning, Nebraska is different than every other state because you have the unicameral legislation, and it's a whole different process. So I'm learning as I go there. The last issue I want to talk about is Medicaid. We're very much involved with that in all 50 states. And by we, I mean NHF and our chapters. In fact, NHF retained a Medicaid consultant a few years ago to help us evaluate the landscape for hemophilia coverage under Medicaid. And so right now, I'll just touch on some trends right now. States are taking greater control over their pharmacy benefit in the Medicaid program, really to control rising costs. That's the issue, is new drugs, expensive drugs that are coming out. States are trying to get a handle on those expenses. And since we have expensive drugs, we have to work really closely with Medicaid. One of the things going on right now, Michigan is moving forward, basically creating a single state formulary that all the managed care companies have to use. So rather than X number of managed care companies all having their own formulary and us dealing with a dozen different formularies, the state is taking control of that. They're going to have one formulary Texas did this a few years ago. It's certainly beneficial for us. That change went into effect for last October. And our chapter in Michigan was very much involved in that to make sure there was no change in how hemophilia was covered. So the Nevada proposal I talked about, you can see here, this proposed carve out, we ended up testifying in front of the Nevada, I guess it was the Drug Use Review Board that had a public hearing on the state's proposal back in December. We then met with the state agency after that. They actually, in the end, they withdrew their proposal in December, reached out to us with an alternative proposal, and they're basically carving hemophilia out of this proposal. So that was a huge benefit, and that was really due to the hard work of our Nevada chapter on that, and their relationship they had with the state Medicaid agency, because we had been building that relationship for the last couple of years. California is still in the process of transitioning their pharmacy benefit in Medi-Cal, which is their Medicaid program, out of managed care to fee-for-service. That keeps getting delayed. It was supposed to take effect in January 1, now it's April 1st. But again, you see the trend here is the state's taking greater control over drug costs in their state. New York is still trying to carve out their pharmacy benefit from managed care. That's supposed to take effect April 1st. I saw an article today that there's been legislation introduced in the Senate to overturn that. So these things, nothing is ever done, no matter what. And so some legislators are trying to overturn that now. So anyway, stay tuned on this. This is something we follow very closely. Our biggest issue and concern with Medicaid is if states decide to manage, if you will, hemophilia products on what's called a preferred drug list, which is a Medicaid formulary, basically. And in a preferred drug list, which we saw in Nebraska last year, Nebraska established one 2 years ago, the state can then limit, they can say, these drugs are preferred, these drugs are non-preferred. And if you're on a non-preferred drug, you might have to jump through a few hoops to get that non-preferred drug, because the state wants you to take a preferred drug because it's less expensive for them. 22 states are now managing bleeding disorders product on preferred drug lists. It was 20 last year. Every year we lose a few more, and this has been a priority for us to work on this. And for example, Maureen and I worked on a letter last year in Nebraska. Their Pharmacy and Therapeutics Committee for the Medicaid agency proposed a new preferred drug list, and states review these every year. Nebraska reviewed its in November, and the proposal they came up with, they moved a huge chunk of products over to non-preferred. In fact, I think there's only 5 or 6 factor VIII products now on the preferred side, and that's exactly what we worry about, is that our patients have more limited access to the drugs they need. So that's why we are opposed to PDLs. I just got a notice, Alaska's P&T committee is reviewing hemophilia next month. I'm going to try to testify. Right now, all of our products are preferred, but you never know when they're going to start moving them into non-preferred. So we try to make sure and testify and work with the chapter on that. So
I think that will be a focus for us this year after the big changes of last year that kind of happened under the radar during the pandemic. And there wasn't an opportunity for any of us, I think, that we were aware of to testify. And a lot of our meds moved on to the non-preferred list. And I believe that there's only one hemophilia B medication on the preferred list. So as we're getting closer to that testimonial time here in Nebraska, which is usually in October, I think we will be working with our advocates and looking for advocates who've been affected by those changes or would be affected were they not grandfathered into that. So that will also be a focus of like our year-round advocacy as well.
And I think that's probably a good state for you and I to have a meeting with the agency before October. If there's opportunity, even if it's a virtual meeting, I think it's been a priority. I think that's why we were successful in Nevada. Betsy and I went in and met with the agency 2 years ago, and they were very candid and with us and really great to work with. So I think that's something probably you and I are going to need to do sometime this summer, and just do the bleeding disorder one-on-one presentation. That's really all it is. So anyway, something to look forward to.
Advocacy
last issue,
sucks, right, Bill?
Yeah. Last issue, really quickly, the state of Tennessee moved their Medicaid program to a block grant. approach, which was approved by the Trump administration at the end of the year. No one knows how this is going to go. It's something we're very concerned about. We're not sure if the new administration can overturn that. But one of the components of that is what's called a closed formulary. So the state can they can establish a closed formulary, which is even worse than a preferred drug list, because, for example, with a closed formulary, they would only be required to offer one drug per class. So for us, it would be one factor 8 product, one factor 9 product, et cetera, one product for VWD. It's something we're very concerned about and something we're going to keep a close eye on and how that's implemented. And at least we don't expect that to go anywhere else. Any other states to adopt that with the Biden administration, the CMS will probably reject it, but it's already the cat's out of the bag or the horse is out of the barn in Tennessee, and we're trying to deal with that now. And that's kind of everything I had.
Can I ask a quick question on your perspective on moving our advocacy efforts this past year to virtual, and kind of like a quick, like top 3, maybe like things that you have seen be really successful with virtual advocacy, and maybe things that haven't gone as well, that we could kind of steer away from as we're living in this virtual space.
Sure. Yeah, it's been a learning experience for everybody. I actually participated in my first virtual Washington Days with another organization. I was invited to talk about gene therapy, and that was actually last April. That was my first experience actually participating, not organizing anything. And I learned a lot of lessons from that. And we shared them with our chapters. There's been a lot of webinars put on by different organizations in DC. I just sent one out to all the chapter EDs day before yesterday on how to host a virtual fly-in. Number one, I think we implemented many of those for Washington Days. And I know some people felt like it was a lot of time commitment because we had things going on each day. But really the key was, requiring people to attend that virtual training on Monday, which we did. And that was really kind of like the same training we would do in DC. I think the big difference was on that Tuesday, we asked NHF staff who were to use their Ring Central or Zoom accounts to have teams meet themselves to get to know each other and talk before the meetings on Wednesday and Thursday. I found that as a participant, again, last April, that opportunity to meet with people, something in the case of my meetings, with people I didn't even know. So we decided who was going to say what and how the meetings were going to go. And that was critical since you're never all together in the same room. For example, if you go to Washington Days, everybody shows up. So let's say you've got a meeting at 10 o'clock. You try to get your group together about 9:50 to meet out in the hallway. And out in the hallway, everybody says, okay, you get everybody fired up to say, I'm going to do introductions. You're going to tell your story. And you kind of appoint everybody before you go in the room, you all get together. Well, you can't really do that virtually, or it's difficult to do that. So I think doing that day before made a huge difference. The other thing, I'm learning stuff from chapters every day. In fact, I have asked her to post it on the NHF chapter coffee shop. Betsy Van Dusen developed something for their advocacy day, their virtual electronic postcards with pictures of a family and telling their story on the right-hand side. I think it's a great idea. I've asked her to share it with other chapters. It's a great way to virtually connect with people. Nice tool, really nice tool there. I'm trying to think what else. The other thing that we've got some of the feedback I noticed in another a 2-page document I'm going to be sending out to the chapter execs that I downloaded yesterday. Legislative staff, as opposed to a meeting when you're in person, when you hand your leave behind at the end of the meeting, they like to have as much information in advance as possible. Because in some cases, like with Washington Days, there are staffers that could not come on, they could not use the platform on their work computer and come on camera. So they had to do it over the phone. So that posed some challenges. But with them having our package in advance, it made the meetings go a little bit smoother because we couldn't do that leave behind thing at the end or really show much. So making sure legislative staffers have things in advance is critical. Um, there are chapters that are being really creative right now in scheduling meetings with legislators. I know last year, Rich Pizzillo in Rhode Island, um, the New England Bleeding Disorders Coalition had an advocacy meeting where they had presentations from their staff, and they also invited a legislator to come on from Massachusetts who has a bleeding disorder. And he was with the group for probably 15 or 20 minutes. In some cases, it's actually easier to get a legislator to participate in things virtually than it is to have them show up in person, or for you to show up in the Capitol. So we showed on the state advocacy training on Friday after Washington Days, we had Michelle Kim, who's the executive director from Southern California, talk about how she secured a video from a congressman in her district to welcome people for their walk fundraiser. And again, she said, we never would have been able to do this in person, but the virtual world made it possible. So there are some creative things going on out there. I learn about them every day, and we're really encouraging the chapters to share that stuff with each other.
Well, thank you. I think it'll be exciting to see how our advocacy efforts grow with having more options available to us this way. So thank you for giving us such a wonderful overview on Washington Days and all of the big legislative hurdles that are affecting the bleeding disorders community now. So if we have any questions as we finish our training this evening, we'll be able to reach out to you and get some feedback. So thank you always for your guidance on advocacy in the bleeding disorder community and for our chapter.
You're welcome, Maureen. I'm happy to do it. Look forward to seeing you guys in person someday.
Thank you.